right, I think we'll get started. Thank you, everybody, for coming. I have the pleasure of introducing our speakers today because Missy is on a catamaran in Mexico. Jealous, right? So today we have Dr. DiNardo and Dr. Bonificino. They both completed their internal medicine residency here at Pitt. They both did a chief year here at Pitt. Dr. DiNardo completed her master's in medical education during her first couple years of faculty at the VA, where she remains as a clinician educator. Dr. Bonificino is currently completing her master's in medical education as a VA Women's Health Fellow. They're both part of a bigger committee that teaches clinical reasoning here at Pitt that's run and funded by Dr. Follansbee. And I think if you want to pick their brains about how to teach clinical reasoning at the end of the program, that they would be happy to share their innovative teaching methods with you. Today, they are here to talk about teaching clinical reasoning to early learners.
All right, hi everybody. Like Sarah said, I'm Debbie DiNardo. I think I know a lot of the people in the room. Like she said, we're going to talk a little bit about potentially some thoughts on how to match your teaching methods with the minds of your learners, and we're going to focus specifically on early learners. And what I mean by early learners is our preclinical and early clinical medical students. Okay, so before we get started, we'd like to get to know a little bit about all of you, if that's okay. Starting off, I'd like to ask sort of what the specialty spread is in the room. So how many people are general internal medicine? I know there are a number of, okay. Other specialties in medicine, okay. Non-medicine specialties, surgery, pediatrics, okay. And then how many people would consider themselves primarily clinical versus basic science? Okay, great, that's helpful. And then how many people would say that they spend a decent amount of their teaching time with undergraduate medical learners? Okay. So everybody else in the room is more time with graduate medical education. Okay. And of those who spend some time with undergraduate medical education, how many have some experiences with the early years, MS1 and MS2? Okay. So about half of us. Okay. A few more questions for you guys. How and when do medical students learn clinical reasoning and medical decision making? What do you think?
I think a lot of it is almost taught by example. Like it seems like it's very rarely is it made explicit to undergrad, like particularly MS1 and MS2s. Like I think of like when we teach like APE and stuff. I think a lot of the times when we're discussing cases with them or having them present cases, we're sort of talking out loud with our thoughts, but we're not saying this is clinical reasoning. We're more, same with MS3s on the wards, they're watching their residents, their interns, and their attendings come up with answers.
Okay, so I hear learn by doing and maybe learn by working with role models. Okay, any other thoughts?
I think case-based learning, which I don't know where exactly they get that in the first 2 years, but if they're PBLs that take cases and people reason through them.
So case-based learning even earlier and before they reach the clinical years is an opportunity to learn clinical reasoning. Okay? Okay. What about these early learners? And this is a little bit what you already mentioned, Dr. Brooks. Any other thoughts on how our early learners in the preclinical years learn clinical reasoning other than maybe during PBL sessions?
There is some popular literature that addresses this, like patient stories.
Okay.
New York Times. Diagnostic cases.
So maybe some stuff that's outside the classroom. And what are the barriers to teaching clinical reasoning at this level, or if you haven't done that, to even the idea of teaching clinical reasoning to this type of learner? Yeah, Ruth.
You have to have certain baseline knowledge
Mm-hmm.
to use.
Okay.
If you don't have it, it's hard to.
So without a sufficient knowledge base, it can be hard to teach clinical decision making. Okay. Yeah.
I don't know this for a fact, but I think probably with switching to the organ-based systems, that there is an opportunity there to potentially do more, complete based cases to sort of develop clinical clinical reasoning once they've learned that block of information.
Okay, so potentially an opportunity and a barrier there. An opportunity to work clinical reasoning into case-based stuff. But the barrier is that it can be hard to do that depending on where in their year they are, and maybe depending on who the teachers are, whether the teachers themselves are clinically oriented and have experience with clinical reasoning. Okay. Any other thoughts before we move on? Yeah.
You know, it's interesting because clinical reasoning is difficult because of the clinical part, right?
Mm-hmm.
But I was just thinking was the idea of teaching reasoning and teaching logic is sort of almost something separate. And I don't, at least not in my medical school, was there I really ever presented with sort of logic-based or like teaching reasoning sort of separate of clinical, and then like, because I think that's the hard part is clinical, but you can sort of separate those and then sort of begin to bring them
So
together.
could you teach things about the reasoning process really separated from the medical knowledge and then marry them again later? I think that's an interesting thought, and we'll maybe come back to that a little bit later. Yeah.
I think a major problem in that context is what is tacit for the professors or for practitioners. It has to be taught deliberately, and then it becomes tacit later on. So there's this funny divide.
Mm-hmm. Mm-hmm. Dr. Painter?
That's what I was going to say. Is that the teacher may be operating at a different level, maybe reasoning in a different way than the learner is, may not realize that.
Great. And we're going to come back to that too. And so a lot of times our clinical teachers are who we consider our clinical experts. They're excellent at medical decision making and clinical reasoning. But how do you get people at that level to communicate with people who are at a much lower level so that there's the type of learning that we're looking for? Okay. Thank you for sharing all of that. And I think we're going to cover and touch on a lot of what you guys brought up. Our objectives for today are first to summarize a leading theory regarding how expertise in medicine develops in general. And then second, to present a developmental approach to teaching clinical reasoning across a spectrum of learners. And like I said in the beginning, we're really going to focus here on those early learners. And then finally, we'll demonstrate some case-based and interactive methods for teaching clinical reasoning at the medical student level. And we'll focus on how each of these fits into the developmental approach that we present. So let's get started. Just a little bit of brief background for why this matters and why we as educators should care about this. A number of different institutions have called for and highlighted the need for better training in decision making. So in 2015, a lot of you may be familiar with the fact that the IOM released a report entitled Improving Diagnosis in Healthcare. In this report, they really called out the importance of diagnostic error as a problem related to patient safety, but also highlighted the urgent need for better training in medical decision making across all disciplines and at all levels of training. This is consistent with goals that the AAMC has for undergraduate medical education, saying that medical students need to have demonstration of sound clinical reasoning and that this is a core competency. And the University of Pittsburgh School of Medicine also lists demonstration of sound clinical reasoning as an objective for its medical students. So this is something that's important both on a larger and more local scale. So how do we go about tackling some of these objectives and meeting some of these needs? I think it comes down to two essential questions, and we're going to go through each of these questions one at a time. The first is, how does expertise in medicine develop? How do clinical reasoning skills develop? We need to understand that before we can understand how to teach them. And then the second is there anything out there that can help us understand which educational approaches may be ideally suited to teaching clinical reasoning at each stage of development? So let's start with the first question. And I'd like to start with an example. Consider this case. A 24-year-old man with a history of IV drug use presents to the emergency department with chills and fever. He also reports sweats, extreme fatigue, and dyspnea on exertion. He appears unwell, is febrile, tachycardic, and has low blood pressure. Track marks are noted on his extremities. And what I'm going to do now is give you two different learners' sort of perceptions of this patient, okay? So the first learner is Bob, okay? Bob says this man must have been using contaminated needles, which led to an infection with gram-negative bacteria. These bacteria in the bloodstream lead to activation of antibodies, which explain the fever reaction. The high temperature, the shaking chills, the sweating, the feelings of extreme weakness, and the shortness of breath. The bacteria also release endotoxins, leading to vasodilation of the arteries. Vasodilation in turn leads to the observed drop in blood pressure and possibly shock, and Bob goes on from there. Okay? Another learner, Lisa, says this. This drug user has developed sepsis as a result of using contaminated needles. Okay. So how are Bob and Lisa different? And I'll give you guys the first one. Bob doesn't have legs and Lisa does. Okay? But how else are they different? Is one better than the other?
It could just be that they differ in what they think are the expectations for how to explain a story.
Okay.
So for all we know, if we probe Lisa, she might say the exact same thing.
Okay. So we don't know that Lisa doesn't have all those details and all of that sort of pathophysiologic knowledge, but she's not going to necessarily bring that up unless asked. We don't know. Okay. Yeah.
I would argue that Lisa is probably like, if I'm assuming like that these were both like medical students. I'm assuming that she's like an MS3, MS4, has seen seen sepsis on the wards before, where Bob is still relying on his pathophys and micro knowledge.
Okay.
And so he's talking out it through this is what happens when you as if he just finished microbiology.
Okay. So good. So your sense is that Lisa may be more advanced in her training than Bob, and that she may even have some clinical experience, or if not clinical experience, some more case-based experience. And that Bob, who actually gave a pretty good description, right? Maybe better than some of us would give, that Bob his mind is in pathophysiology right now, which sort of suggests maybe he's earlier. Are you going to add something?
I was thinking about just consolidation.
Okay. What do you mean by that?
She has consolidated more of her knowledge in pathophysiology into something that's more practically useful.
Okay.
Because she used the term sepsis.
Uh-huh. Great. So we're going to come back to that word consolidated in a minute. So the next question is, how does someone at Bob's level get to Lisa's level? Okay, and we're going to assume that these are both good, smart students, and like Carla said, that if you probed Lisa, potentially she has that pathophysiologic knowledge in there somewhere. So earlier cognitive theories suggested that the development of expertise is a process of knowledge expansion. And so the way that you become an expert is that you learn more, you get more knowledge, and then you're able to apply that knowledge, okay? More recently, theories have focused on the fact that potentially the development of expertise is a process that involves knowledge shifts and knowledge restructuring. And so what this means is that you have your baseline set of knowledge, and yes, that continues to grow over time. But really, to develop expertise, you need to make connections between pieces of knowledge and be able to apply that knowledge in more nuanced ways, and that's how you become an expert. And moving forward, I'm going to talk about one more recent theory that sort of fits with that paradigm that I just discussed, and it's called the encapsulation illness script paradigm, okay? And I have it mapped out on this timeline here, and we're going to go through each of these stages one at a time. This paradigm suggests that there are really 4 stages to the development of medical expertise. The first is probably where Bob is, okay? In this first stage, clinical reasoning is really dominated by causal networks, where learners tend to explain disease in terms of underlying pathophysiology. In the next stage, encapsulation of these pathophysiologic concepts happen, and they turn into diagnostic labels and syndromes. And don't worry if some of these words are a little vague, because I'm going to go through each one of these items one at a time in a minute. In the third stage, learners develop illness scripts by acquiring experience-based and contextual knowledge. And then finally, those illness scripts are refined and stored, and this is a process that goes on and on and on and on, even after our formal training has completed. Okay, so let's go through each of these stages one at a time with the goal of understanding this process better before we move on to talking about educational methods that might be well suited to help students move from one stage to the next. Okay, so as I mentioned, stage 1 is a stage where there is the development of these causal or pathophysiologic networks. Learners in this stage tend to explain the causes and consequences of disease in terms of pathophysiology, in terms of biology. The evidence that this stage exists mostly comes from studies that use sort of think aloud protocols, where clinicians and students at various levels of training are asked to think aloud about their reasoning regarding a patient case. And these studies have found that learners in this stage tend to focus on isolated signs and symptoms and attempt to relate them to pathophysiology, and that those characteristics are really absent once you get to more expert level think alouds. Not surprisingly, this requires a lot of effort. It's prone to error. And interestingly, when this has been studied, a lot of times in these protocols, the early learners in this stage would remember a lot more details of the case than the more advanced learner, with the theory that potentially the early learner can't decide what's important or not, and so they grasp onto everything. And when you become more advanced, you're able to more easily let go of the things that don't matter or don't impact your thinking. Moving on, stage 2 is entitled encapsulation. And in this stage, those networks of pathophysiologic knowledge become encapsulated into diagnostic labels or higher level sort of pathophysiologic models, okay? How learners get here is they have repeated application of that pathophysiologic knowledge, and really importantly, exposure to patient problems is thought to be important from getting from stage 1 to stage 2. And I highlight this because it gets to the whole move in medical education to go toward organ system type blocks and to incorporate patient type problems into early medical student education. So in thinking about stage 1 versus stage 2, think back to Bob versus Lisa. So Lisa used sepsis, and you could label sepsis as sort of an encapsulated diagnostic label, whereas Bob used much more complicated pathophysiologic explanations. Stage 3 involves the development of illness scripts. In this stage, that encapsulated knowledge is reorganized into illness script, and just so we're all on the same page, an illness script is a pattern of findings that evokes a specific disease. And you may be wondering, what's the difference between an encapsulated description and an illness script? Encapsulation, the stage of encapsulation still relies heavily on pathophysiology. When you get to the stage of illness script, the thought is it's dependent much more on sort of clinical or contextual information, so patient characteristics and risk factors and that sort of thing, as opposed to pathophysiologic mechanisms of disease. So let's go through a couple of examples of illness script. Just shout this out. What do you guys think when I say a young female on OCPs with pleuritic chest pain and hypoxia? PE, right? That fits everybody in the room's illness script for PE. What about middle-aged male with acute onset burning pain, a vesicular RAS, and a dermatomal distribution? Shingles, okay? And so these are the types of patterns that are developing during stage 3. How do learners get here? It's thought that clinical and patient-based experience is very important for this, not surprisingly. And in general, when faced with a case, learners in this stage will first search for an illness script that matches the elements of the case. And then, if no illness script is available or the case is difficult or complicated, go back to their pathophysiologic knowledge and use it. And I think this is important, one, because of what you said, Carla. So the fact that we move on doesn't mean that we should let go of the pathophysiology or that it's not important. And in fact, we really want our students to have a very strong basis in pathophysiologic knowledge so that they can go back to it if some of these higher level pattern recognition and illness script processes don't work. The final stages where the illness scripts are stored and refined. Learners get here through lots more clinical experience and practice, and then really importantly from feedback. So feedback from both unsuccessful and successful diagnoses. That patient that I thought had pneumonia came back 2 days later with PE. Where did my thinking go wrong? Where was my illness script off? I'm going to readjust. Not surprisingly, experts have more illness scripts for a given disease than novices. And even more important than the number of illness scripts is sort of the nuanced presentations of disease that experts are able to incorporate into their illness scripts. And it's thought that once you get to the expert level, sometimes you have an individual illness script that's based on a single patient. You know, a patient that came in really atypically forms an illness script in your mind. Okay, so we've now reviewed the 4 stages of expertise development according to the encapsulation illness script paradigm that you can see here. And I think it makes sense now to take a moment just to kind of explicitly talk about where our medical students at various levels might fall along the spectrum, okay? I think we would probably all agree that when our learners start out, they are very appropriately wrapped up in pathophysiology and that they're operating in stage 1. I think we would hope that as they get into the latter half of their preclinical years and are preparing to enter the clinical setting, we hope that we have supported them to get into this encapsulation phase so that they're prepared to develop their illness scripts when they have the opportunity to see lots of patients. And that the refinement of illness scripts probably starts even during the 3rd year and then continues on, as I mentioned before. Yeah.
I just want to make a point about going back to Bob and Lisa. It's still bothering me a little bit.
Yeah.
We're making an assumption that Lisa does have that causal mechanism in place, and I just want to point out it's an assumption, because I've certainly had a lot of 3rd-year learners who use these encapsulated things. That's Parkinson's, but when you ask them about the pathophys, they really don't understand it.
I think that's a really great point. So we are making an assumption, and I didn't give you guys enough information about Bob and Lisa to know where Lisa really was and whether she was where you would want her to be or not. But I think that sort of reemphasizes my point that that the pathophysiology is actually really important. And although we want to support people in developing their encapsulation and illness scripts, we don't want to forget about that first part. Yeah.
So let's just say that you're not in a teaching role
Mm-hmm.
and you're an advanced clinician. Like, at what point does the pathophysiology no longer matter?
I think that the people who come up with this paradigm would argue that it always matters, because that's what you're supposed to go back to when a case is not proceeding as expected, when you don't have an illness script that matches, when the case is really complicated, that's what's going to potentially be helpful.
I just think it's interesting because, when you think about maintenance of certification, making sure that physicians still know their stuff,
you
really don't get tested on that, nor does CME focus on that. I'm just throwing that out there.
Yeah, no, I think that's a good point.
I don't think it's emphasized. I think it's obviously emphasized in the training realm.
Yeah.
But I don't think it's emphasized in the practicing realm.
Yeah, I think that's a really good point. I don't know, there may be studies out there. I don't know if there are any that have probed into sort of how much intact pathophysiologic knowledge do experts have, but that would be an interesting question. Okay, so let's move on to the,
I was a little surprised at the way you put the years of the students. I was surprised by the fact that by MS2 there was encapsulation, and I've only been doing this for a year and a half, and that they were at the expert level by MS4. I almost would argue that you need some residency to kind of get to.
Yeah, and so this continuum does not imply that when you get to stage 4 you're an expert. This is more talking about the stages that you go through, and we could map residence on to here as well, and there would be overlap. So I don't mean to say that once you get to stage 4 you're done, you've got it, you're an expert, and that's it. I think as far as the MS1s and MS2 having some encapsulation, again, it's sort of a continuum, and when Eliana gets up and talks a little bit later, she's going to give some examples of things that are relevant there, and will hopefully help answer your question. Yeah.
Just to follow up on that, there are at least a couple studies that looked at very early learners, and they do pattern recognition even when they don't have patterns to recognize. Because you have to think about something. You have to start somewhere. So what they start with is, this is chest pain. They pick something, and then they start reasoning from that diagnosis. And they may alter that, but they do encapsulate very early.
Yeah.
At least empirically, it seems that's the way our minds work. Is we have to latch onto something and then work from there. We can't just start with the basic pathophysiology.
And your point that they're just having illness scripts doesn't mean your illness scripts are right is a good one. And probing your learners about your illness scripts, I think, is an important way to uncover deficits that may not be apparent from the surface. Okay, so we're going to move on now to the second question: which educational approaches are ideally suited to each stage of development? And the short answer to that is we don't know for sure, but I am going to talk to you a little bit about what data is out there and propose some ideas and some thought-provoking things, and at the end we're going to ask you guys for some ideas too. So I'm going to start by talking about this narrative review that was published in 2015, and they really systematically searched the literature for any studies that looked at teaching clinical reasoning, and they really looked across lots of different levels. They broke down the studies they found by two criteria. What overall approach was taken in the educational intervention? Was it a knowledge-oriented approach, and within that, was the knowledge-oriented approach mostly based on pathophysiology, or was it based on distinguishing between different diseases based on clinical factors? And then secondly, was it a process-oriented approach? So was it really not based on knowledge, but just based on teaching about the clinical reasoning process? The next criterion that they sort of divided studies based on was how cases were delivered. Almost all of these studies that look at teaching clinical reasoning use some sort of case-based method. Some of them used cases that sort of would gradually unfold over time, sort of simulating the real medical decision-making process, and this is called the serial cue approach. And then others would provide an entire case up front and then ask learners to dissect the case in different ways. So we don't have time to go in detail through all of their findings, but I'd like to give you a bird's eye view and then kind of drill down on some of the things that are most relevant to what we're talking about today. In general, they reviewed 48 papers. 24 of them had empirical findings, and there really weren't enough objective findings to allow for any pooling of data to come up with summary results. Most of the educational interventions that were studied used clinical cases, but they were variable in terms of whether they were written, simulated, or real. There was really variable formats, anything from one-time sessions to much more longitudinal curricula. Overall, one of their take-home points is really that the evidence regarding the efficacy of methods for teaching clinical reasoning is lacking, and that we need more study and investigation in this arena, which I think is true. They also, in general, found that educational methods that target the clinical reasoning process in isolation based on the data seem to fail. And so when it's not sort of anchored to a knowledge-based process, just teaching about how clinical reasoning works doesn't necessarily tend to improve educational outcomes. And as I'm going to talk about, there's potentially some evidence to support a developmental approach to teaching clinical reasoning, and the authors of this article sort of proposed some methods that they thought seemed to fit at various points along that developmental spectrum that we just talked about. So this is the spectrum that you guys are probably getting a little bit tired of seeing. Okay, so we've got the 4 stages and my hypotheses about where our students might fit along this spectrum. And what we're going to talk about now is some specific educational methods that might be well suited to teaching learners at each level, and importantly to helping learners moving from one stage to the next. Okay, and so the first set of methods we're going to talk about are methods that may support going from the stage 1, where everything is about pathophysiology, into encapsulation, and those are called self-explanation and example-based learning, or EBL. So what is self-explanation? Self-explanation is an active learning process where students explain to themselves a few things. 1, how the findings present in a case may have been produced by the underlying pathophysiology. 2, how the signs and symptoms relate to one another. And 3, how the signs and symptoms relate to possible diagnoses being considered for the case. And when this is studied, it's done as sort of a talk to yourself, think out loud exercise, but including all of these specific things. Think back to our learner, Bob, and how he talked through the pathophysiology of that patient with sepsis. So what about the evidence for self-explanation? This is actually something that has been studied for a much longer period of time in other educational areas outside of medicine, and there is some evidence to support it as an effective learning method for knowledge development. Within medicine, more recently, there have been investigations that have mostly been with clerkship level medical students. So I'm going to talk about a couple of them now. In 2 studies, the use of self-explanation on written cases was found to have a positive effect on student diagnostic performance on subsequent written cases. So these were different cases that the students did a week later. The benefit, like I said, was seen 1 week later on different and more difficult cases than the ones they used the self-explanation for, suggesting that this method may lead to transfer and sort of more deeper levels of learning that can be applied in the future, which is what we want, right? Interestingly, the benefit in these studies was seen only when the case topic was quote unquote unfamiliar. And so if it was a topic that the student was really familiar with already and had a lot of knowledge, this method didn't seem to make a difference, but if it was a less familiar topic, it did. And we're going to talk a little bit more later about what that might mean. They went on to review the transcripts from the student self-explanations from one of those studies, and they found that overall students used more explanation. They talked through things more when they had an unfamiliar case topic, which sort of makes sense, and that they used more pathophysiologic language when self-explaining less familiar cases. And remember, I said that the only improvement that they saw was with these less familiar cases. Now I'm going to move on to talk about example-based learning, which is sort of a related method to self-explanation. Example-based learning is, simply put, the process of learning or acquiring skills by observing examples or role models of that skill. And when it's been studied in this medical setting, which has only been fairly recently, what it's really included is having a resident or an attending or another person self-explain a case and having the student listen to that and incorporate that listening into their approach, okay? One study found that when a student did their own self-explanation and then listened to a junior resident's self-explanation of the same case, they did better than students who had done their own self-explanation alone. And they found more effect when students were prompted while listening to the resident self-explanation. So when the students were given specific prompts of consider how the pathophysiology relates, there were actually a set of 12 different prompts that they used to kind of trigger the students' minds in particular ways while they were listening to the resident self-explanation, they did better. So what are the implications for what I just went over for each of these methods for educators? It seems like self-explanation and example-based learning may be effective in engaging students in more active learning or active problem solving, and that there's some early data to suggest that use of these methods could lead to more deep and transferable learning, which is what we're all shooting for. And the theories for why this works is that potentially the creation of connections between pathophysiology and clinical knowledge is what's important here and what allows a student to potentially move from a stage 1 to a stage 2. So how could this be incorporated into teaching early learners? So I think self-explanation is something that is not hard to do as long as you understand what needs to be involved, and that it could probably be incorporated into some of the early educational experiences that our medical students have, like problem-based learning. Eliana is going to talk a little bit more about something that we've done recently that involves example-based learning. And then in the clinical setting, the data that we reviewed highlights to me that potentially having our residents be better at doing this sort of self-explanation in front of students may be a valuable teaching technique. And I want to differentiate this from just the whole talk out loud, because a resident sort of just talking in general out loud about their thinking doesn't necessarily achieve this goal, and there are really specific things that need to be included in order to kind of line up with how this method was studied. Okay, so now we're going to talk a little bit about deliberate reflection, a method that may be ideal for helping learners to get from the encapsulation to the illness script phase. So the premise for use of this method is that students need practice that allows for comparing and contrasting of adjacent diseases. And when I say adjacent diseases, I mean diseases with overlap in terms of symptoms. So acute viral hepatitis and choledocholithiasis can both present with acute onset right upper quadrant pain and vomiting, but students need to understand how they may differ in other ways. Or a single disease that manifests in different ways, so the varying different presentations of myocardial infarction. Deliberate reflection involves explicit comparison of different diseases and which elements of the case fit and don't fit with each one. This has been studied a lot actually at the resident level, but specifically at the medical student level. It's been found that there was better student diagnostic performance when compared to using deliberate reflection, when compared to just having the student give their diagnosis, and also compared to prompting the student to give a differential diagnosis. So this is better than just saying, give a differential diagnosis. In a couple of other studies, students who compared and contrasted ECGs of different diagnoses performed better than students who looked at the same ECGs but had them grouped according to diagnosis. So the compare and contrast seems to be really important to learning. So what are the implications for this method? I think one big thing I took away from this is just coming up with a differential diagnosis is not enough. It's the justification and the what fits and what doesn't fit with each diagnosis on the list that may help lead to more connections and learning that can be applied in future cases. In terms of incorporating this with early learners, I think there are a few ways. From an individual and learner-directed way, encouraging our learners to be deliberate and active when they're evaluating cases and to go through this compare and contrast process, either verbally or in a written form. Encouraging case-based horizontal reading as sort of a method for learning. And when I say horizontal reading, I mean Eliana had a patient with chest pain on wards, and instead of just going home and reading about pericarditis, which is what her patient has, she's going to go home and read about what are all the different things that could cause a chest pain like this patient came in with, and how do they compare and contrast based on a number of factors. And that's going to allow her to come up with an algorithm and a framework that she could apply to a different patient in the future who came in with similar chest pain but ended up with a different diagnosis. And then getting feedback from the teacher about how you're compare and contrast and how you're sort of prioritizing things on your differential, I think is also really important here and important for refining illness scripts. From a group and team setting, especially when you get into the clinical rotations, participating in out loud, deliberate reflection with peers and with coaches has been touted as a potential educational method. And I think this is exactly what we do in our student teaching attending sessions. And then, of course, the think out loud in the real clinical setting. Okay, I'm going to touch very briefly on the serial cue method just to round things out, but I'm not going to belabor it because, as I'm going to discuss, it's thought that it's a less ideal method for early learners. So as I mentioned, the serial cue approach uses cases that gradually unfold, prompting the learner to simulate the real medical decision making. This has high face validity, right? Like, why wouldn't we want to expose our learners to cases in the most real fashion possible? And according to that narrative review, this is probably the most common type of case delivery that's used, really despite not very much evidence supporting it. It's really thought to be not ideal for very early learners for a couple of reasons. One, they don't have well-developed illness scripts, and so when they get a little snippet of a case in the beginning, it's very hard for them to know where to go from there, what questions to ask. And because of that, it's thought to create a pretty high cognitive load situation that may actually hinder instead of help learning. And I don't have time to go through it now, but there's some evidence suggesting that for very early learners, potentially giving them the whole case up front and then going through the exercises may be better from a learning standpoint. Okay. So that was a whirlwind tour of the sort of developmental paradigm and a few different methods. Now Eliana is going to come up and talk to us a little bit about some specific issues related to Pitt Med.
Debbie, can I just ask, for the deliberate reflection piece, you mentioned that it, at least the way that it was studied, it incorporates very specific prompts, right, as opposed to just the think aloud, which is a little bit more.
Do you mean the example-based learning?
Yeah.
Yeah, and so...
Is that because they've been studied against each other, or just like, just general think aloud versus the...
So the reason that there are very specific prompts for the example-based learning, and that's where I'm a student and Sarah's my resident, and she's going to explain her approach to the case out loud, and I'm going to benefit from that. And that when they studied it, if someone was telling me, think about this, think about that, while she was talking, these are general prompts that come from outside of like the medicine literature related to these methods, self-explanation, example-based learning. So they're actually not knowledge-oriented or in any way suggestive of what the answer is. It's more thought-provoking. So how does that change your thinking? How does the underlying pathophysiology relate? And then a lot of prompts on how does her approach compare to what you were thinking? And that going through those specific things made a difference, and that students who did their own self-explanation and listened to someone else's, but just kind of on their own with no prompts, still did better than the control group, but not as well as the students who had sort of like the framework provided for them. I don't know if that answers your question.
And I just wanted to know if it was like they were compared against each other,
Oh,
or
gotcha.
just if the prompts were studied, and that's why we're saying that's like more valuable.
Yeah, the prompts came from other arenas looking at these educational methods. That's why they use them.
Okay, so now we're going to transition into how these methods can or are currently being used to operationalize the knowledge that Debbie talked about. And in particular, we talked about how the causal networks and encapsulation can or may be best paired with self-explanation and example-based learning. And the ways that they are currently being done here at Pitt Med are the following. The first is the organ system-based curriculum, and the second is PBL sessions, with the third being a new clinical reasoning case conference that's being introduced in the first year. So behind me is the map of the curriculum for the first and second year medical students here at Pitt Med. And like we talked about, the early years, like medical anatomy, here at human genetics, fuel metabolism, cell biology, that all fits really well with explaining the causal networks of disease. And then as you progress further on with immunology, medical microbiology, and the organ system-based blocks, that also helps both with pathophysiology, but also with encapsulation of that knowledge. There's a big red arrow there pointing out on immunology, and that's because that's where we actually started this clinical reasoning case conference for the first year medical students. And it just started this past February with an intended second session here in medical microbiology. Before I tell you exactly what a clinical reasoning case conference is, it requires you to accept two premises. The first of which is that having clinical reasoning terminology helps you form a scaffolding with which educators can verbalize their thought processes to students. That means if I tell my third year medical student on wards that someone who comes in with tachypnea and hypoxia after a recent surgery fits my illness script for pulmonary embolism, they understand what an illness script is, and that helps them sort of further define their own illness scripts. The second, which we've discussed, is that role modeling, or this example-based learning, is a powerful tool that can help you illustrate reasoning, foster reflection, and encourage the self-regulation. And this is also supported by the American College of Physicians Teaching Clinical Reasoning Guidebook. So the first year conference. The outline is the following. One is that there's an introduction where we introduce a common clinical reasoning terminology, and we do one at a time with an intended one added on to the next as it progresses. And that's consistent with the theory to teach the process in the context of knowledge. The second is a case presentation. So you introduce an unknown, and it's quote unquote unknown because the students don't know exactly what the case will be. And then we utilize that skill that we taught just a second ago during that case presentation. The third is that there's a discussion, and that's using both the example-based learning but also the self-explanation with a focus on pathophysiology, which is what they're focusing on their organs, on their block. So we're going to walk through a partial example. And so the students will be introduced to a clinical reasoning concept called key clinical finding. We're going to walk through the history of present illness of a case and try to identify the key clinical findings. And then typically a clinician engages in self-explanation. So I'm going to ask you all to brush off your first year medical student hat and put it on, and to think how you might think about this case as a first year medical student. So, like we talked about, the term that they're introduced to is key clinical finding. And for those of you who don't know, a key clinical finding are elements taken from the patient's history, physical exam, laboratory, and diagnostic testing that help you diagnose the case or narrow the differential diagnosis. And here on the side, you see a screenshot from House, which is all clinical reasoning, by the way. And here you have Dr. Foreman, who's written down the key clinical findings of the case that they're currently discussing. So, my first year medical students, the chief complaint for this case is, I think I have a fever. So Mr. A is a 42-year-old man with a history of alcohol use disorder and splenectomy following a car accident, who presented to the emergency department with 5 days of fever. He states that he was in his usual state of health until about 5 days prior, when he started to develop a sore throat, rhinorrhea, fatigue, and malaise. Over the course of those last 5 days, he developed a cough with production of thick yellow-colored sputum, concurrent fevers to 101.5 degrees Fahrenheit, and due to this worsening illness, he opted to present to the emergency department for further evaluation. At this point, we'd ask the medical students, what are the key clinical findings? So I'm going to ask you what you think a medical student might pull out of that case as a key clinical finding. You can just shout it out. Fever. Cough. Sputum production. And splenectomy. This is a very, very advanced first-year medical student in the front row here. So what we usually do is we ask the students to engage in self-reflection at that point. So if someone were to have yelled out alcohol use disorder, we would say, so what makes alcohol use disorder a key clinical finding? In which case, someone might say that that increases your risk for aspiration, so we could have an aspiration pneumonia. What we then do is a moderator directs the students towards an expert clinician. So then I would say, Dr. DiNardo, what do you identify as the key clinical findings of this case? And then they would engage in explanation-based learning and say, you know, a splenectomy really changes the way I think about this case because without a spleen, you are at increased risk of encapsulated organisms. Since after you opsonize your encapsulated organisms, you don't have a spleen to take them out of circulation. And so that way, we tie them to the pathophysiology that they're currently learning. Everyone's laughing here in the front row. There's a lot of pathophysiology. But we're tying it to what they're learning. So moving on to the third year medical students, here we talked about how deliberate reflection might be a good technique to use for them. And there's two things we're going to talk about here. One is this new clinical reasoning curriculum that was implemented this year as part of my master's fellowship project. And the second that fits really nicely in with this is the student teaching attending based sessions. And for those of you who aren't in general internal medicine, it's when the third years are on their clerkship, they get together in groups of 8 students with a faculty member, and they go through cases step by step and discuss their clinical reasoning. So what is this new third-year curriculum? It's in 2 parts, the first of which are online modules, and there were 6 modules that last approximately total 2 hours, and they were developed by the faculty in the Department of Medicine with support from a grant to Dr. Williams Follansbee from the Hearst Foundations. And they contain information on the cognitive psychology of decision-making, heuristics, semantic qualifiers, summary statements, and cognitive biases. And they're interactive, so they have videos, they have prompts for students to enter responses, as well as text that tells them more about those concepts. The second part is a workshop that reviews the concepts and gives them cases and allows for skills and drills in each of those skills. And this includes deliberate reflection. So I'm going to walk you briefly through the tools or the skills that we emphasize in this workshop. The first of which is the idea that clinical reasoning starts with a chief complaint. And that means when you, as your third-year medical student self, gets a patient with right upper quadrant abdominal pain, you start thinking, which of my illness scripts fit with that right upper quadrant abdominal pain? And what we recommend to the students at this point is to create an organizational chart for each diagnosis to help them build their illness scripts. And this fits really nicely in with that deliberate reflection. For example, this is taken from ACP's Teaching Clinical Reasoning. And this is an example of a chart that we encourage students to make on their third-year rotations. So if you get a patient with chest pain, you would start with saying, oh, this could be a myocardial infarction, it could be an aortic dissection. And we ask them to look up and fill in this kind of chart, which is who gets it, the epidemiological factors with it, how does it usually present, what are the clinical manifestations I look for in physical exam, what are diagnostic tests I might use to diagnose this, and then you can also include one for typical therapy for those particular conditions. This allows for a really nice side-by-side comparison of your illness scripts for different complaints, different possible etiologies for one primary complaint. The second we touched on in our first year session, which is identifying key clinical findings, which here includes translation into semantic qualifiers. And you might be asking, what's a semantic qualifier? And so I've provided a menu here. And these are explicit terms that allow you to categorize patient complaints into things that might have more meaning with regards to a differential diagnosis. So for example, the differential diagnosis for acute diarrhea is very different from that of chronic diarrhea. And by translating what the patient tells you with regards to time into a semantic qualifier, it really drives your differential diagnosis one way or the other. The third skill we have them practice is framing your case into a summary statement. And we tell them there's 3 particular critical components to a summary statement, the first of which is providing the clinical context, having a temporal pattern for those complaints, and also incorporating some of those key clinical symptoms and exam findings. We have them practice with cases, and then we have them pick out things that they may or may not have included with summary statements that they see for other cases. And the last skill in our toolbox is to formulate your assessment and plan. And we break this down into the following. One is the creation of a problem list based on the patient's case. We prioritize that list, and then we create differential diagnoses for each problem. The main part of this, though, is a discussion of why and why not each is a differential diagnosis and why you think it's most likely. And there's a nice framework that was introduced by Baker from Rush Medical Center in Teaching and Learning in Medicine, and they say that this is what you should ask your students to do. It's tell me your ideas. 1 is to provide that interpretive summary. 2 is give differential diagnosis with a commitment to what's the most likely. The E is the explanation of your rationale for the above, and A is the discussion of alternatives. And that really ties nicely into this idea of deliberate reflection. So, at this point, we talked to you a little bit about what we've been doing on the medical student side. So we want to hear your thoughts. So the questions we want to hear is, how might you change any of your teaching activities to incorporate these ideas of developmental approach? And do you see any barriers with which you would do this? And what we'll have you do is we'll give you 1 minute and you can turn to your partner and discuss, and then we'll come back in a large group. Okay, so we're going to bring you back into the big group. That's my projecting voice. Okay, so what are some ideas that you might have come up with in your groups?
I have a good question. And so you have a very explicit, structured MS1 introduction of what the strategy is all about. What happens in MS2 for the organ blocks? How are you going to do that?
So we plan to continue that same block by block clinical reasoning case conference and add on to the prior terms that we learned. Does that answer your question?
So you're going to teach in each of the organ systems, there's going to be a scaffolding of this somehow?
Sure, go ahead.
See, because it goes from MS1, you have a very directed, structured approach, which sounds great. Then I'm thinking, okay, then in MS2s, is it going to go diffuse? Because it's, because it's going to be more of a challenge to introduce it in such a directed and explicit and structured way through all the different organ systems. How's that?
Sure. So one way to answer that question is, I think there are things going on already in sort of the existing curriculum that sort of are in line with these.
That's what I'm worried about.
That
we're
talking about. In terms of what we are specifically doing, the clinical reasoning case conference is something that we hope to get a 1-hour time slot in each of the blocks going forward. And so the plan is for that to continue, and that it'll be sort of a building longitudinal experience where we introduce terms and talk about that terminology. I think it's worthwhile discussing whether there are other ways to incorporate this stuff into educational activities that already exist.
And the other, to sort of build off that, so I think this is great, but like in teaching them these terms, illness scripts, teaching them these thoughts. I'm wondering, because a lot of this is medicine based, the surgeons, are we teaching them to use the same language? Like, so when they go into the MS3 year, like let's say medicine is their last rotation and they're doing surgery and gynecology, are they getting the same language throughout all of those rotations? Because otherwise.
So I think that's a good point. I'm actually on this clinical reasoning task force that Ankur Doshi runs in the medical school that's multidisciplinary and has representatives from lots of different specialties. And I have to say that coming to an agreement on what the approach to clinical reasoning should be, and another member of the task force is here, which is something that we have tried to do, is probably not likely to happen. Because people, I guess, necessarily approach things in different ways in different specialties. I think that you know, exposing them to all of the basic terminology early on makes it more likely that they're going to be able to continue to use it regardless of what rotation they're on in their
I don't think it's like.
But I do think that sort of involving people from other specialties and some of the efforts that go on in the preclinical stuff would probably be another way to kind of help keep everybody on the same page. And what we plan to do with these clinical reasoning case conferences is whatever block we're in, have somebody from that block be involved in sort of talking through the case. Yeah.
You were advocating for MS1s to use this example-based learning where residents talk out loud through a case. But it's my understanding that most of their contact with residents is not going to occur till MS3 and 4. Is that sort of?
Yeah, so I think example-based learning in general could be used with any person filling the sort of teacher role or the person who's talking through the example. You're right that a lot of the students don't get a lot of exposure until they enter their clinical years. We didn't have time to go through this, but the people who study this have tried to look a little bit at like who is the best example for a student. Like, is it the expert attending? Is it a resident, or is it a peer? This is all very like early data, but what they've found so far is that it seems like maybe the junior resident type person is a better person for the student to learn from with that method than the expert. And the hypothesis is that they're closer together. The resident is better at explaining themselves in a way that's understandable to the student, and that sometimes experts kind of miss the boat because they're too high level. I think another way to approach that though is like in our conference, having very deliberate ways of having the quote-unquote expert explain things, and having I was the quote-unquote expert for immunology, and so I had to do like a lot of reading about opsonization and selectivity and like refresh my memory so that I could talk about pathophysiology and being mindful of who the learning audience is. But I think that's a very valid point.
First of all, this is really terrific, and I think desperately needed, and I really appreciate that you guys have put it today. My deep worry about this, and it is not that anything wrong is happening at all, but that when you set up the explanation that the logical thinking about the pathophysiology is the lowest level, and then you get up to higher things that feel more memorization-y. To me, the biggest problem we have is not that people are getting stuck down on that pathophysiology logic, but that students use memorization as a crutch to get through that period, leave it behind as soon as possible, and then move on to just sheer rote memorization with no thinking behind it. So when I get them in the clinic, sometimes these students, they just vomit up a differential diagnosis that has nothing to do with any sense for how the body works or what's likely with this patient or any of these logical things that you guys are trying desperately to teach. And so I don't know how we sort of defend, I mean, because to me that's the big problem, and we have to be very careful not to teach them in a way that they then feel very proud of themselves because, look, I have left pathophysiology behind. I am an illness script, and I'm sort of, you know what I'm saying? I think that's the real worry with that, and I don't know how you guard against that danger.
I think that's a really good point, and I think, a better way to show that diagram would be to have the arrows for the earlier stages continuing, right? And if these aren't like defined stages, we leave one behind and we move on to the next. And I agree with you that and the people who are sort of experts in this in the literature would agree that keeping the foundation of pathophysiology is really important, and it's what you go to when it's not really
things are a mess and you don't know what's
exactly. As far as how to continue to promote that and how to make sure that our educators are promoting that, I think that's a much bigger question that I don't necessarily have the answer to, but I agree that it's really important.
But I remember professors when I was a medical student, they would exactly ask medical questions, but then had you explain the pathophysiology. Just they brought it all together, so both were equally important.
And these methods would argue that the way that you actually help students advance is by incorporating explanations of pathophysiology into your sort of think out loud stuff. And so maybe part of the intervention is on the students, but part of it is on the teachers too.
as we're using in my student teaching and just kind of have access to the.
Let's talk afterwards about that. Yeah. Thank you so much for coming, everybody.